Okay, now cervical spine fractures are classified into stable and unstable fractures. In stable fractures, the spinal column maintains its stability, and the spinal cord is not at risk of injury. On the contrary, in unstable fractures, the spinal column is unstable and the spinal cord is at risk of injury. Fortunately, stable spinal fractures are more common, and their management includes analgesia and physical therapy. Unstable fractures require neurosurgical intervention, with procedures like spinal fusion, which entails fusing one or more vertebral bodies using plates, rods, or screws, with the goal of artificially regaining the lost spinal stability. To understand cervical spine fractures, the spine is anatomically divided in 3 columns. The anterior column is made of the anterior longitudinal ligament, in the anterior half of the vertebral body. The middle column is made of the posterior half of the vertebral body, in the posterior longitudinal ligament. The posterior column is the remaining posterior aspect of the spine. Generally speaking, anterior column fractures are stable, middle column fractures can be stable or unstable, and the posterior column fractures are the most unstable. Let's take a look at some of the more important unstable fractures you should recognize. Fracture of the atlas, or the C1 vertebrae, is called a Jefferson fracture, and results from an axial load vertically compressing the spine, such as a diver diving in head first, or a football player spearing another. Bilateral facet joint dislocation is also an unstable cervical spine injury that results from hyperflexion of the spine. Another hyperflexion injury is fracture of the odontoid process, also called the dens, which is a small bony protuberance projecting from the axis, or the C2 vertebrae. Odontoid fractures are classified into 3 types, depending on the location. Type 1 is actually a stable fracture, and extends to the tip of the odontoid process. Type 2 extends to the base of the odontoid process, whereas Type 3 extends to the vertebral body, and both are unstable. Next are atlantoaxial dislocations, which is a dislocation between the atlas and the axis below, and atlanto-occipital dislocations, which is a dislocation between the atlas and the occipital bone above. Both may result from hyperflexion or hyperextension of the cervical spine and may be life-threatening. Now, bilateral fracture of the C2 vertebral pedicle is called a hangman's fracture and commonly results from hyperextension injury. It gets its name from its association with judicial hangings, which cause neck hyperextension. Finally, a teardrop fracture usually results from hyperflexion, and is characterized by the avulsion of the anterior-inferior portion of the vertebral body, giving the avulsed fragment a triangular shape that looks like a teardrop, hence the name. This typically occurs in the mid-cervical levels around C4 to C6. You can remember these fractures using the mnemonic Jefferson bit off a hangman's thumb. Jefferson, bit for bilateral facet dislocation, off for odontoid fractures, A for atlantoaxial and atlanto-occipital dislocations, hangman for a hyperextension injury in hangman fractures, and thumb for teardrop fractures. Individuals with cervical spine fractures present with neck pain, which may radiate down the arm if the adjacent nerve roots are compressed. Additionally, early on in reaction to the trauma, the spinal cord temporarily suppresses all of its functions at and below the level of injury, a phenomenon called spinal shock. This includes flaccid paralysis, complete loss of sensation, bowel and bladder paralysis, and causes priapism. This temporary state usually lasts 1 to 2 days, but may extend up to several weeks. During this period, it is not possible to accurately ascertain the degree of neurological injury until the individual has completely recovered from spinal shock. Finally, some spinal cord lesions may result from these fractures and their mechanisms. For example, central cord syndrome resulted from hyperextension injuries, and uniquely manifests as neurological deficit that is greater in the upper extremities compared to the lower extremities. Teardrop fractures may cause anterior cord syndrome because that avulsed fragment can compress the anterior spinal artery, causing ischemia to the anterior 2/3 of the spinal cord. This results in paralysis and loss of pain and temperature, but preservation of the dorsal column functions, such as proprioception, vibration, and two-touch discrimination. Alright, the final form of injury that occurs as a result of blunt neck trauma is vertebral or carotid artery dissection. This can also result from relatively mild trauma, such as chiropractic manipulation of the neck, suddenly checking one's blind spot while driving, or even extending the neck when shaving. A dissection is an intimal tear of the artery that creates a false lumen. This false lumen overwhelms and obstructs the true lumen where blood is flowing, and allows formation of thrombi, causing ischemia to the distal tissues. In cases of vertebral or carotid artery dissection, this manifests as a stroke or transient ischemic attack. Therefore, it's one of the important differentials of strokes in young individuals. In both cases, there is usually a lag time lasting hours between the trauma and the onset of neurological deficit. Internal carotid artery dissection usually presents with unilateral headache, neck pain, and ipsilateral partial Horner syndrome, which includes ptosis, meiosis, but no anhidrosis. This occurs due to ischemia or compression of the sympathetic chain running along the cervical vertebrae. Facial sweating is preserved because those sympathetic fibers run along and are supplied by the external carotid artery, not the internal carotid artery. On the other hand, vertebral artery dissection presents with signs of posterior circulation ischemia, such as ataxia, diplopia, or vertigo. When suspecting either, a CT angiogram is the best initial screening test, as it can adequately detect intimal flaps and luminal occlusion. An alternative is MRA, or magnetic resonance angiography, which is similar to the CT angiogram, but can provide additional details regarding brain ischemia. If the CTA or MRA don't adequately show the dissection, then the gold standard is conventional DSA, or digital subtraction angiography, which best identifies the details of the blood vessels. But it's an invasive procedure, so it's often left as a last resort. Management of carotid or vertebral artery dissection starts with anticoagulation using heparin, followed by warfarin. The mainstay of treatment is endovascular stenting of the involved vessel. As for thrombolysis using TPA, the general consensus is that the same guidelines applied to an ischemic stroke should also apply here. So only give it if the individual presents within 3 to 4.5 hours and has no contraindications to TPA. Importantly, TPA is contraindicated if the dissection extends intracranially or if it involves the aorta. Alright, quick recap. Neck trauma is classified into penetrating trauma, such as stabs or gunshot wounds, and blunt neck trauma, such as motor vehicle accidents. Penetrating neck injury is defined by violation of the platysma muscle. When approaching penetrating neck injury, start with the ABCs: airway, breathing, and circulation. The airway is secured by orotracheal intubation, or if necessary, emergent cricothyrotomy. Cervical collars are usually unnecessary in penetrating neck injury, unless there is a concomitant blunt neck injury or neurological deficit is present. Zone 1 injuries can involve the mediastinum, so it's important to assess for a pneumothorax. Control hemorrhage by direct pressure on the wound, and if that doesn't suffice, then a Foley catheter is inflated in the wound to tamponade the bleed. Next, if the individual is hemodynamically unstable, they should be taken to the operating room immediately. If hemodynamically stable, assess for hard signs like air bubbling from the wound, subcutaneous emphysema, stridor, a rapidly expanding or pulsatile hematoma, an audible vascular bruit, active brisk bleeding, massive hemoptysis, and an absent or weak radial pulse. If any of these are present, the individual should be taken to the operating room. If absent, look for the presence of soft signs, such as dysphagia or hoarseness. The subsequent management depends on the zone of the neck involved. Zone 1 and Zone 3 injuries should be assessed by a CT angiogram. Zone 2 injuries are usually taken to the operating room. However, another recently adopted path is to do a CT angiogram first. The CT angiogram assesses for vascular, laryngotracheal, and pharyngoesophageal injury and will determine the subsequent management. If the CT is equivocal, then esophagoscopy or bronchoscopy can be done. Okay, as for blunt neck trauma, a major concern is cervical spine injury. Similarly, start with the ABCs. However, an emphasis is placed on immobilizing the cervical spine using a cervical collar. Next, apply clinical decision tools such as the Nexus or Canadian C-spine rule, which will help determine if the C-spine is cleared or if CT imaging is necessary. The CT can detect a multitude of stable fractures, which do not require surgical management, and unstable fractures, which do.